Good morning. Today we are going to discuss a recent article about sirolimus and skin cancer prevention in kidney transplant patients. This article was published in the New England Journal of Medicine this year. As a background, uh, skin cancers after organ transplantation has been a huge issue, and a decent place in literature to get a review on this is this article in NEJM. This is not the article that's in question right now. We are going to talk about a different article that has been just published lately. Skin cancers affect more than half of organ transplant recipients during their long-term course. Squamous cell and basal cell carcinomas account for more than 90% of all skin cancer in transplant recipients. The incidence of these carcinomas increase with the duration of immunosuppressive therapy, ultimately affecting 50% or more of Caucasian transplant recipients. For example, the cumulative incidence of skin cancer in transplant recipients in Queensland, Australia, in one such study, increased from 7% after 1 year of immunosuppressive therapy to as high as 82% after 20 years. Amongst Dutch patients or Dutch transplant recipients, uh, in one of the English studies, the incidence of skin cancers at 1 year was 0.2%, and the long-term incidence went as high as 41%. Squamous cell carcinoma is the most common skin cancer in transplant recipients. Skin tumors in transplant recipients can be of various categories. Here is a table showing the tumor type and cells of origin of each tumors. Basal cell and squamous cell carcinomas, as well as some pre-malignant lesions like actinic keratosis or Bowen's disease, arise from epidermal and hair follicle keratinocytes. Melanoma arises from melanocytes and nevus cells. Kaposi sarcoma, angiosarcoma arises from endothelial cells. Neuroendocrine skin carcinoma arises from the Merkel cells, which are the neuroendocrine cells. Lymphoma arises from B and T lymphocytes, and there can be a skin variant of that. Malignant fibrous histiocytoma arises from the fibroblastic cells or histiocytic cells. These pictures demonstrate the squamous cell carcinoma in transplant recipients. Panel A shows a squamous cell carcinoma of the helix. Panel B shows pre-malignant keratosis and warts in a male recipient of a heart transplant. And panel C shows aggressive squamous cell carcinoma of the toe of a patient who has been transplanted 16 years ago. Calcineurin inhibitors, by a mechanism which is independent of the immunosuppression, can enhance tumor development, and this has been debated as well as proposed in various animal models. mTOR inhibitors, mammalian targets of rapamycin, are newer immunosuppression which has some inherent anti-neoplastic properties. mTOR inhibitors interrupt PI3K AKT pathway, which is a pathway that plays a critical role in the regulation of cell proliferation, survival, angiogenesis, and mobility. As of now, we have two mTOR inhibitors which are approved for treatment of metastatic renal cancer, Sirolimus and Everolimus. The current study that is in discussion is an attempt to know whether sirolimus is useful in prevention of secondary skin cancer. Sirolimus is manufactured by Pfizer, and the brand name is Rapamune. Everolimus is manufactured by Novartis, and the brand name that is used for transplant population is called Zortress. The brand that is used for metastatic renal cancer is a different name, Afinitor. So this is our original article published in New England Journal of Medicine. It's Sirolimus and secondary skin cancer prevention in kidney transplant recipient. This is a part of Tumor study group, uh, and the primary location was in France, but it's a multi-center study. The study received grants from French Ministry of Health, French Society of Dermatology, and Pfizer, but the sponsors had no role in the trial design or collection or interpretation of data or even writing of the report. The enrolled patients met the eligibility criteria that there should be kidney transplant recipients, there should be calcineurin inhibitor use, stable renal function, and at least one post-transplant cutaneous squamous cell carcinoma invasive. The patients that were excluded were multi-organ transplant recipients, history of organ rejection during the past 6 months before enrollment, poor graft function before enrollment, which is quantified by eGFR less than 30 or 24-hour urine protein creatinine ratio greater than 1 grams, or a 24-hour urine protein level greater than 1 grams, uncontrolled hyperlipidemia, hematological disorders, hepatic disorder, retinoid treatment. The dose limits on immunosuppression that was set for the study was glucocorticoids 10 milligrams or less of prednisone. Azathioprine, if it was used at a dose of 1 milligram or less per kilogram body weight per day. If mycophenolate was used, the dose was kept 1.5 grams or less per day. The target trough level for the calcium inhibitor cyclosporine was 75 to 125 nanograms per milliliter, and the target trough level if tacrolimus was used as a calcineurin inhibitor was set at 4 to 7 nanograms per milliliter. In the initial randomization, 129 patients were actually randomized, out of which 9 were excluded because 4 were lost to follow-up and 5 did not meet the inclusion criteria completely. So that left with that. Then the study group was left with 120 patients, out of which 64 were assigned to Sirolimus group and 56 were assigned to calcineurin inhibitor group. If it was a one-to-one randomization, this does not make greatest of the sense, but at the end of 2-year follow-up period, the patients were equally distributed in the two groups. At the end of 1 year, 49 remained in the Sirolimus group and 59 patients remained in the tacrolimus group or calcineurin inhibitor group. And the reasons were either the patients dropped out of the study or withdrew the consent or had some adverse event that needed a switch from one group to the other group. And at the end of 2-year period, 42 patients remained in the Sirolimus group and 44 patients remained in the calcineurin inhibitor group. What kind of clinical evaluations were done during the study period? The clinical evaluations that includes dermatology and nephrology examination at enrollment and at every 3 months. At the dermatologic visits, at the initial enrollment, the skin type was classified based on Fitzpatrick's classification. Eye and hair color was determined. Sun exposure was measured, and the sun exposure was scored on the basis of occupational and leisure exposure, where 1 is a low exposure, 2 is a medium exposure, and 3 is a high exposure. Or use of tanning beds, if it was never used, the score was 1. If it was occasionally used, it was 2. And if there was a regular use of tanning bed, the score was 3. And if a patient was a resident of a tropical area for more than 6 months, they scored 1. And if they were not a resident for more than 6 months in a tropical area, the score was 1. And if they were a resident, the score was 2. So based on no or yes. At the dermatology visits, the skin tumors or the pre-malignant lesions were histologically determined, like squamous cell or basal cell carcinoma, keratoacanthoma, Bowen's disease, pre-malignant keratosis, or other rare cancers. At each and every visits for each and every patient in both the group, sun protection was advised. At the nephrology visits in the transplant clinics, the dose of immunosuppressants, the clinical determination of acute organ transplant rejection, assessment of serum creatinine, 24-hour urine protein, and drug levels were measured at every 3 months in the calcineurin inhibitor group. In the Sirolimus group, the serum creatinine, the 24-hour urine protein, drug levels were measured weekly for the first 2 weeks and monthly during the subsequent 3 months, and then every 3 months. The study endpoints. The primary endpoint was survival free of cutaneous or new cutaneous squamous cell carcinoma at 2 years, and the secondary endpoints were time until the onset of new lesions, occurrence of other skin and non-skin lesions, and obviously the kidney or the renal graft function. The patient characteristics in both the groups were fairly even. The sex distribution was almost the same. The age distribution was almost the same. The skin type distribution was almost the same. Eye color and hair color also fairly evenly matched out in both the groups. The patients with squamous cell carcinoma, those who had single lesions, were 35 in the Sirolimus group and 31 in the calcineurin inhibitor group, and the percent was 55% in each. The patients with multiple lesions were 29 in the Sirolimus group and 25 in the calcineurin inhibitor group. The interval between the diagnosis of most recent squamous cell carcinoma and randomization was also close. It was 4.5 months in the Sirolimus group and 6 months in the calcineurin inhibitor group. Sun exposure was also even. The number of transplantation before randomization was also fairly even, as long as there was one transplant. There was a slight higher proportion of patients with more than 2 transplants in the Sirolimus group as opposed to calcineurin inhibitor group. The patients on dialysis before transplants were also fairly equally distributed in both the group. And the 24-hour protein was on a median average was 0.1 grams in Sirolimus group, and calcineurin inhibitor it was 0.1 grams. If you look at the range went all the way from 0 to 0.98 grams in the Sirolimus group and 0 to 0.73 grams in the calcineurin inhibitor group. So although the median number was fairly okay in terms of proteinuria, but the range was quite varied, and it went as high as close to 1 grams. And that was a surprising fact that patients being on Sirolimus, the study took a step forward and included patients with a decent proteinuria, although it was less than a gram. If you look at the results, there were a total of 290 cutaneous squamous cell cancer lesions in 120 patients at baseline, out of which 55% had single lesions and 68% had a total of 274 other biopsy-proven skin tumors. 84% of the patients were on cyclosporine, 36% of the patients were on tacrolimus. If you look at the results, the survival-free time was significantly longer in the Sirolimus group. I repeat, the survival-free of cutaneous squamous cell carcinoma was significantly lower in the Sirolimus group. The hazards ratio for the new carcinoma was 0.37% in this. So if you look at the probability of survival free of new squamous cell carcinoma, and you look at the curve on axis, that is month after randomization, you can see that as early as around 3 to 4 months you can start seeing the difference between the two groups. The probability of survival free of new lesion was higher, much higher in the sirolimus group as opposed to calcineurin inhibitor group, and that suppression stayed in statistical relevance as high as 25 months. When a patient had a single squamous cell lesion, the survival was noticeable. The survival free of new cancer, new squamous cell carcinoma was noticeable in the sirolimus group as opposed to the calcineurin inhibitor group. But when the patients had more than one squamous cell lesion, there was an overlap right in the initial part, and that skewed the idea. But after the first few months, there was clearly a difference between the two groups, where sirolimus group had a longer period of survival free of cancers, new cancers, skin cancers. If you look at the outcome data, 22% of the patients in the sirolimus group developed new cutaneous squamous cell carcinoma, and 39% of the patients in the calcineurin inhibitor group developed that. The median interval of development of new lesion, which was a squamous cell lesion, was 15 months in the sirolimus group, and it was 7 months in the calcineurin inhibitor group. The decrease in the ratio of squamous cell to basal cell carcinoma was 1.4 from 3.9 in the sirolimus group, and that ratio was decreased to 1.0 from 1.8 in the calcineurin inhibitor group. Among the patients in sirolimus group with new cutaneous squamous cell carcinoma lesions, it developed 6 months after the withdrawal of the drug, with maximum exposure of 4.1 months. If you look at the dermatological results, the number of patients evaluated in the sirolimus group was 42, and the calcineurin inhibitor group patients were 44, and this is at 2 years. And you can go through the table. Patients with at least one new non-melanoma skin cancer was 16 in the sirolimus group and 28 in the calcineurin inhibitor group. If you look at the percent, it was 38% in the sirolimus group and 64% in the calcineurin inhibitor group, and that's a clearly high number with a statistical significance. This patient with at least one new non-melanoma skin cancer in a group which already had a single squamous cell carcinoma before randomization was higher in the calcineurin inhibitor group as opposed to the sirolimus group. In the patients which had several cutaneous squamous cell carcinoma before randomization, the patients with one new non-melanoma skin cancer was higher in the calcineurin inhibitor group as opposed to sirolimus group, but that difference did not attain statistical significance. The patients with other non-skin cancers like colon, prostate, or lung, kidney, or lymphoma was there in both the group. An important mention should be of the adverse events. Most of the adverse events occurred during the first 6 months of the study. Adverse events were definitely more in the sirolimus group. A lower sirolimus dose or a complementary specific treatments were able to control most of the adverse events. Adverse events in the sirolimus group led to discontinuation of the drug in 15 patients, that is 23% of the patients, after a median exposure of 2.5 months. And this is the list of all the adverse events that happened. If you look at the adverse events, just as a rough view, you can see that the number of events were more in the sirolimus group. The edema was more in the sirolimus group. Aphthous ulcers were more in the sirolimus group. Proteinuria was significantly more in the sirolimus group. Pneumonitis was more in the sirolimus group as opposed to calcineurin inhibitor group, and 13 such patients had actually serious adverse event. Same way, rash was more in the sirolimus group. Arthralgias or cough was more in the sirolimus group. The UTIs were almost equal in the two groups. Herpes simplex lesion was surprisingly more in the Sirolimus group. The patients were classified, the patients that were in the Sirolimus group and that were converted from calcineurin to Sirolimus were divided into two divisions. The group 1 were the patients who were converted to sirolimus with rapid protocols, and those are the patients who got the conversion from calcineurin inhibitors to sirolimus before 7 days. And those patients who got the conversion that took longer than 7 days to convert from calcineurin inhibitors to sirolimus were called to be in a regular protocol. So 36 of the 64 patients were a part of rapid protocol, and those patients who were converted slowly were considered as the progressive protocol conversion. So the rate of discontinuation of the drug was higher in the rapid protocol conversion group as opposed to the progressive protocol conversion group. The rate of pneumonitis was higher in the rapid protocol conversion group, and obviously the serious adverse events were much higher in the rapid protocol conversion. So overall, the study inference that we get from this current study is that switching from calcineurin inhibitors to sirolimus in this study population showed a decreased risk of new squamous cell skin carcinoma and the delayed occurrence of such non-melanoma skin lesions. The serious adverse events were significantly more in the sirolimus group, and the number of squamous cell skin carcinoma was lowered by a factor of 3.4 in the sirolimus group. The benefit to risk ratio appeared to increase if we used a lower dose of sirolimus, if the patients got a lower dose of sirolimus, or if there was a progressive conversion rather than rapid conversion. This study is so far one such study which has looked into this aspect of secondary skin cancer prevention. The only clinically relevant information that is missing is the quantification of proteinuria. How bad was the proteinuria in the sirolimus group? And that definitely can be found from the appendix, but at this point on the published material we don't see that, which is an important factor because proteinuria, as we know, has been shown to be worsened by use of sirolimus, and we definitely need to know the comfort zone where we can expect the proteinuria to get worse with sirolimus. All in all, um, this is a step forward towards knowing a clinical concept of secondary prevention of skin carcinoma, especially the squamous cell skin carcinoma, because in Caucasian population this comprises one of the major post-transplant complication, and that needs to be rectified. At least the ways to tackle that needs to be identified, and this study is a step forward to know that. And that leaves me with the end of presentation. Thank you.